เซสชันถัดไปนะคะจะเป็นหัวข้อเรื่อง Conceptualizing the Global Physician through Selected Accreditation Frameworks บรรยายโดยProfessor Associated Professor ธนากร จิรเสวีจินดานะคะท่านมาจาก Weill Cornell Medical College นิวยอร์กค่ะ
I'm saying good evening or good morning from New York City, where I'm based at Weill Cornell Medical College in New York City. It's really great to join you, really a privilege to be able to join you at your annual Congress. I really would like to thank the organizing committee for inviting me. And then also I want to say hello to distinguished faculty members who have joined this session. Secondly, I would like to congratulate or offer my congratulations to Dean Sutipong and Ajahn Nijasi and their team in really enrolling successfully the inaugural class of students at CU Medi. And I've met them. They are enthusiastic, they are diverse, and I'm really confident that they're going to be really successful. So Ajahn Nijasi asked me to discuss some topic related to global physician training. And I wanted to just think about this topic as conceptualizing the global physician through selective accreditation framework. And I'll go through what that all means. I play some roles in as an editor or associate editor in a couple of journals, but I will not be discussing my roles during this talk. So I wanted to say first that the topic I've chosen, right, to train the global physician is quite closely aligned to the new medical program, international medical program, CU Medi's mission. And that's really fourfold, as you can see from the slide here, and I've taken a screenshot from the website as well. So first is really, CU Medi is unique in that it is offering students international experience. It also offers innovative technology. And lastly, the two other points that I think are really very important are to train multi-talented global doctors and also leadership for change, which, as we will see later, these are excellent or necessary qualities for being a physician in the 21st century. So I'll start off by sharing a little bit about myself, just so that you can get some context of why this topic really interests me. This is sort of the journey where I've taken from elementary school, junior high school, where I spent most of the time in Thailand. And then afterwards, I went on to Taiwan for school, and already there was some cross-cultural experiences. I went to college studying biological sciences and painting. I was a studio art painting major at Stanford. And those are the formative years of my life. Afterwards, I did go to medical school residency in various parts of the US. And then I joined faculty at Albert Einstein College of Medicine. Afterwards, had some training and now ended up at Weill Cornell Medical College since 2007. In 2008, I formed a really direct, close working relationship with the Faculty of Medicine at Chulalongkorn University. It's been a really fruitful and productive partnership, and thanks to the previous deans and presently Dean Sutipong, along with Ajahn Anop and his team. And then the sort of last squares, I wanted to say that I have recently received the Fulbright Fellowship for faculty training, which will enable me to spend 6 months in Bangkok with the new CU Medi program and really working with the group on curriculum enhancement as a consultant. I'm really excited about that. So then I wanted to just point out that, my straddling different nationalities and cultures really has led me to focus my efforts and experience in medical education in the areas of healthcare communication, cross-cultural or cultural competency, global health, and professional identity formation. These are the topics and areas that are really important to CU Medi. So to start off, before we talk about the globalized physician, what it means to be a global doctor, it's good to step back and think about what globalization really means. Traditionally, globalization has largely referred to an economical concept or economic or financial thing, which really is associated with open markets, free trade, free movement of people and capital and assets around the world, right? And in this way, globalization then is defined as the process of interaction and integration amongst people, companies, governments of different nations, and all that is driven by international trade and investment and aided by information technology, right? And IT plays a huge role now in the 21st century. Well, you may say, TJ, then how does it, apply to healthcare as we know it? So I would argue that globalization has really impacted healthcare delivery a great deal. You see the graphics there of how the delivery of medicine has become complicated, right? There is sophisticated testing, there is IT, there is human contact, there's a lot of some of these other aspects of healthcare delivery. So then globalized healthcare delivery really results from increasing immigration and emigration from different countries, across national borders and continents even. It is a result of a movement of providers across national borders, right? People go to different countries to train, bring back, expertise, et cetera, to practice in their own home country. The rise of medical tourism, I think we cannot deny that fact. Increased complexity of medicine and medical knowledge. I'm quoting from Gene to Population. This is a phrase that Johns Hopkins used a few years ago when they were doing reform of the curriculum. So it's really thinking about the very minute thing from genetic stuff, basic science, to really population health and public health. And lastly, really the distribution of medical subspecialties, right? Certain subspecialties are concentrated in urban areas versus rural areas in certain countries, etc. So then globalization, I would say, then has really trickled down to medical education because healthcare delivery oftentimes has a direct impact on medical education. Ron Harden in 2006, and Ron is the president of the Association of AMI, the Association of International Medical Education. And he uses the word internationalization of medical education. And for him, it's really fueled by globalization of healthcare delivery, which we talked about, right? There's some governmental pressure or governmental priorities. There's improved communication channels between the different entities, development of common vocabulary across the different countries, outcomes-based education and standards, and really thinking about what it means to graduate a medical doctor who is able to do X, Y, Z, right? It hinges on, depends on staff development initiatives, and lastly, competition and commercialization, which we acknowledge. So globalized medical education has a precedent at July. And I have to say that a couple of things. One, preparing for this talk has taken me to doing some reading and research to think about what medical education is like in Thailand. And that has given me a really good understanding about medical education in my home country. The second thing is I wanted to say that, at the end, I might not be able to offer, I will offer some solutions, some things to think about, but I think it's just as important that, I raise some questions for everybody to think about, right? So global medical education has a precedent at July, and part of my preparation got me here. There are two quotes I want to share with you. It was written in 1996 in a journal called Medical Education, which is one of the top medical education journal here in the English-speaking countries. And the first quote is really talking about medical education responds to change in medical practice, right? And I sort of talked about that before. The process must be dynamic, meaning it cannot just stay the same. It needs to change every few years in response to the changing healthcare system or healthcare delivery. And changes are occurring around the world, as we know. Secondly, international cooperation is needed now more than ever. And you might wonder who was the person who this quote is attributed to. And I would show you that this quote is a John Suwanwela, who again was written this in 1996 in medical education. And Ajahn is now is a very own professor emeritus at Chulalongkorn University Faculty of Medicine. So medical education response to healthcare practice, what does that mean? It means it really has been changing. And according to this article, it talks about the socio-economic factors and political movements, including urbanization, industrialization, and demographic shifts that impact healthcare delivery. Secondly, there's a lot of advances in medical science, coupled with consumer demand, and then added to that the increase costs and new ethical issues with the new advances has brought about. And lastly, influence from industries such as pharmaceuticals, investors, insurance structures, all that stuff has an impact on the direction of medical education. So within the same article, right, Ajahn Suwanwela really discuss a lot about the history of medical education in Thailand, and I've learned that it's really full of different examples of international cooperation, starting off with the Rockefeller Foundation in the 1910s, and then later the World Health Organization, how those needs affect the direction of medical education in Thailand has taken. Then after that, McMaster University and Maastricht University, the premier medical education universities, have really also lent some content and some pedagogical teaching to medical education in Thailand. And most recently, with the World Federation of Medical Education, has had some conference proceedings that generate some content that also generate or influence the direction of medical education in Thailand. So in that article, it's also quite clear that international cooperation leads to change, and there needs to be continued cooperation. And international cooperation leads to change by providing an impetus or drive for change from the outside. And then it also provides a compelling reason for applying and adapting successful approaches that have been used elsewhere, right? Problem-based learning, or the interactive way of engaging learners. And then the second point is that international cooperation leads to accreditation, or the need to do the accreditation to make sure that the programs and curriculum that we have received accreditation of the bodies to really get credit. So accreditation and recognition of medical schools and medical education really help facilitate the progress of medical education, and then they can drive policy decisions about education in medicine in general. So when we think about education, right, we think about, a call for framework, or it needs a framework. And for me, a framework really focuses on how the different parts of the puzzle, how they fit together, how the training leads to competence, how competence leads to patient outcome, etc. And so the most commonly used competency-based or outcomes-based education as a framework really answers two important questions. One is, what do we expect our learners to do? And the second thing is, who do we expect them to become at the end of their training? So to answer these questions, we step back a little bit, right? I want to go through a little bit of a history lesson to think about the state of our current medical education in the US and in Canada, how did it come about? So we started off with this man, Abraham Flexner, in 1910. Flexner was a researcher who has a brother who was a dean at Johns Hopkins Medical School. And basically in 1910, he decided to look at all the new medical schools and old medical schools in the US. And he realized that, a lot of the medical schools there have very different levels of quality, I should say, right? Some of them really should not be open. And so at the end, when he went around the country, visited different programs, and he came up with these recommendations, he said the medical colleges should really affiliate with academic universities, universities that can really have rigorous, science, rigorous teaching, rigorous, backup or faculty appointments, etc. And secondly, he really, really expounds the virtue of scientific method to really make sure that we know what we're teaching and standardize it. And thirdly, he came up with the concept of postgraduate medical school education, meaning that, before students start medical school training, they really should finish their bachelor degree. And once that happens, they study science and other fields, and then they go on to medical school. And he also came up with this 2+2 system, meaning out of the 4 years of medical school, 2 of them are preclinical basic science, and then followed by clinical education to solidify the application. So you can imagine, right, in the beginning it was really great. There were some great medical schools that came out of that muddy field, and Johns Hopkins was one of them. And then many, many other medical schools closed because they really did not have the quality. But at the same time, there's some unintended consequences, and those unintended consequences really refers to or result in the tyranny of science, meaning we are so focusing on science that some of the other things we forget about. Okay. And then also a lot of this curriculum is rigid. They depend on memorization and not creative learning or active learning. It's rigid. There is a schism or a big gap, big divide between basic science and clinical application, which is not the best thing. Then came 100 years later, 1 century later, Molly Cook and David Irby and one other colleague in 2010, did a similar thing by looking at the state of the medical school education and really wrote a book called Educating Physicians. Their idea is to undo some of the unintended consequences of the Flexner report from 1910. They made 4 recommendations, which again, I hope that you get that these recommendations refer in many ways back to what CU Medi's mission is. One is to make sure that the medical education incorporates early integration of clinical application into the basic science, right? So there's no 2 years of basic science, 2 years of clinical anymore. Everything should be taught together, integrated. We really should be generating or fostering habits of inquiry with medical students. They should not just memorize, but they should think and ask questions and investigate. The third thing is we want to make sure that we produce really competent doctors and compassionate doctors, but offer some flexibility how they can achieve that. And then lastly, to really foster professional identity formation. How do you make, children, adolescents, and young adults, right? Once they enter medical school, when they graduate, who do they become? What is that professional identity that they assume they become later? So with that background in mind, I will now go over the 2 most common, or the framework for assessment, a framework for accreditation, and I'm familiar with, and these come from the accreditation for the residency program. So the first one is in the US. It comes from the Accreditation Council for Graduate Medical Education, or many of you know it as the ACGME. That came out in 1997, and basically it generated 6 different competency areas, right? These are the core competencies. And then you sort of see that oftentimes, you see I've outlined there medical knowledge and patient care. These are the 2 areas that traditionally we have focused on the most, right? And that's really in line with Flexner initially, thinking about the science aspect and the scientific foundation of medicine. But then the ACGME added these 4 other things, which I think really to be a global physician, to be any modern physician, we really should pay much more attention to. One is interprofessional communication skills. I think that's really important. Another one is professionalism. You can see how that's important. The other two are not as obvious to people. One is practice-based learning and improvement. And that really talks about how the learner and practitioners learn to find the best evidence and to apply that evidence and really to take into account patient preferences, sort of in line with the previous speaker talking about what patients would like and what their preference are about their cataract surgery, okay? And then also thinking about how can you make improvement and identify areas or opportunities for improvement. The last competency area is systems-based practice. And for me, it's clearer, and it may not be as clear to our learners. It's really thinking about how do you make improvement in the systems, right? Think about cost-effective care, think about efficiency in healthcare delivery, and think about, how do we make improvement in that environment on the systems level, not just on the individual level. So the second or the next framework I want to show you guys and discuss is from the Royal College of Physicians and Surgeons of Canada, and that's called CanMeds, or Canadian Medical Meds. They really, when we talk about the ACGME, right, it talks about tasks-based or skills-based, right? You think about communication skills, you think about patient care, you think about systems-based practice. Those are the skills that you need to learn and exhibit and apply. The Canadian system talks about roles as a person, roles as a provider. And so at the middle of that, in contrast to being competencies areas, it talks about medical expert. How does one become a medical expert, right? First of all, you have to be a professional. So really self-regulated, transferability and self-reflection. And then you have to be able to communicate, be a communicator, and then be a collaborator, again, working with that system, but working in partnership with other people, generating trust and autonomy with others. Manager, right? How do you do the sustainability, making sure that you manage your team and manage the people you work with? Cultural safety and consensus, and then a holistic practice and a recognition as a health advocate. How do we advocate for patients? And then lastly, as a scholar, right? As a researcher, as an application of researcher, and then sharing research. So you can sort of see the wisdom of dividing it into roles versus skills-based. So next, I want to share with you the medical education hot topics that have continued to come up in the last 5 to 10 years. And I think you can sort of see how these areas and these components respond to the framework that I showed you, and also to CU Medi's mission for their curriculum. So the first thing is really thinking about, curriculum content, right? These are the three areas: curriculum content, pedagogy and assessment, and lastly, learner development. I've sort of divided them up into three different buckets. So with these, you can see are some of the quote unquote, not just soft skills, but important skills, right? One other previous speaker spoke about the fact that you can very much get all the information at your fingertips with an iPhone, with a smartphone, with a computer, etc. Right? Many of these curricular contents, add to that medical knowledge, add to that, fund of knowledge by really practicing humanistic practice, professionalism, cultural competency, family and patient-centered care, right? Health equity is a big thing. And then you can see the rest of it: social determinant of health, how where you live, what you do as an occupation, your education level really impact people's health. Okay. The next thing is really pedagogy and assessment areas, right? I've included interprofessional education. So education is not just siloed with medical students. What about training together with nursing students, with social worker students, with pharmacy students? And there are plenty of examples about that. And then talking about competency-based assessment, simulation, peer education are really hot topics right now. Community engagement and service learning, right? How do you learn to take care of patients by engaging in the community with public health, population health, and really advocating for patients? And then service learning is a similar concept. And then lastly, with regards to the learner and learner professional development, think about their well-being and self-care. Think about some generational issues. I think you would agree with me that Generation X, Gen Y, the millennium, etc., they have a different learning style, different values, etc. And so how do we meet those needs? Professional identity formation and individualized learning, again, thinking about how do we do learner-centered education. So while I'm offering a lot of these thoughts for solutions, I would also, along with some of my colleagues, advise caution. And some of those cautions are really due to the fact that we don't want to fit a square peg, right? This red peg, which is square, we don't want to force it into a round hole. And that, what I mean by that is you may have accreditation framework and curriculum from other international programs and other countries. They may sound really nice, like fantastic, shiny new toys and great, wonderful opportunities to apply. But at the same time, think about if you apply them en bloc without modification. That approach can create unintended consequences, right? So really the idea is to think about the context, think about culture, the local culture, think about how you can apply and whether the new package, the new something, is it really applicable to the student body, to the faculty that you're trying to apply to? And this is, some of my colleagues in Taiwan and in the Netherlands have talked a lot about this, about the adapting curriculum to the local context. I know the hours are late, and so I've spent some time talking about a few things. I want to just close out by offering you a summary. Again, I hope that we agree that there is a need for globalization of medical education in response to changing healthcare delivery. And I think CU Medi is a great way to really start doing that, right, for Thailand. And secondly, think about the role of accreditation framework, how that really helps with, making sure that we implement a quality education for our learners and prepare them for practice in a globalized setting. And lastly, the need to continue international cooperation and having it be a dialogue and just a one-way adapting whatever comes our way. I want to leave you guys, though, also thinking about some parting thoughts and food for thought. One is, how do we incorporate the role of the public into, what we are thinking about, right? Do they have a say in medical education and where we go? What about the role of the learners? We know that the younger generations are quite vocal and very loud and passionate about what they want and need. But at the same time, how do we incorporate them? Is their input, is their feedback really important? And how important is it? And then flexibility, how do we think about individualized learning plan? And then one of my colleagues, in this case in Canada, often talks about we need to do more research to assess the outcomes of medical education interventions that we do, right? Really elevate medical education and research in this area to the level of clinical research, basic science research, so that we know whether what we're doing makes sense and results in good results. And lastly, this is for me and for other people. I do realize, and I think that I need to really check my arrogance and really my sense of centrality with this at the door when I enter that conversation, right? I should really avoid ranking different approaches and thinking, that what I'm familiar with is really superior. It's really not a competition. And so when I do at the end come in December, I want to make sure I'm committed to being a humble learner during my 6 month at CU Medi and really make this a two-way process. So thank you very much for your attention. I really hope that my comments and experience are helpful to everybody.